Welcome to the presentation for Nursing 150 for care of the patient with cancer. In this presentation, we'll just kind of review the development of cancer and care of the patient who has a diagnosis of cancer. The first few slides of this presentation are just specifically just to kind of review how cancer develops. These are just characteristics of normal cells. It's important to understand the characteristics of a normal cell in order to identify what makes a cell a cancerous cell. And the next couple slides kind of are some pictures that give you some visuals as to the difference between a normal cell and a cancerous cell. This is just a visual reminder of the normal cell division, and it's just a good to review this, just to kind of compare this to the development of cancer cells. Cell division in a normal cell is very organized. It's very purposeful. It serves a purpose. Each cell duplicates itself for a purpose to serve a function. For instance, red blood cells form into red blood cells, and they become red blood cells in an organized manner to serve a certain function. It's just a visual so that you can see the difference between a normal cell and a cancer cell. Abnormal cells that can become cancer cells when they are exposed to a condition that alters the normal cell growth and function. So when they're exposed to different things like environment, carcinogens, this can provide an environment to where body cells are exposed to this, and it alters their normal cell growth and function. Cigarette smoking is something in the environment. Pollution is something in the environment that is thought to be a carcinogen. Viruses. Consumption of alcohol is known to be a carcinogen. So it's exposure of these carcinogens in the environment. Viruses as well, like I said, that exposure causes a normal cell that can lead into developing a cancer cell. This picture is just a good way to show the cancer growth, how it develops into another tissue. The green cells here are cancerous cells, and they are typically cancer cells are quickly to divide. They divide in an unorganized manner. They grow quickly. They don't adhere to each other very well. They're just kind of running amok. And essentially what happens is these keep growing and growing and growing, and then they'll kind of just take over this tissue. And then they alter the function of this tissue, because now we have a bunch of cancer abnormal cells as opposed to the normal cells. This looks like skin tissue here. The normal skin tissue is going to be cancerous cells now, and so now they can't function in the way that they were meant to function. Just some more definitions of cancer development. Cancer is abnormal cell regulation. Big word here, it becomes unpredictable. Make yourself familiar with the difference between a benign cell growth and a malignant cell growth. Benign is harmless. It just kind of gets in the way, basically, is what benign cancer cells are. They get in the way of other things. They don't spread. Malignant ones are definitely the indicative of cancer. They are much more serious than the benign. It's just a comparison table here for the difference between benign cells and malignant cells. Features of the benign here. Benign, like they're kind of more similar to a normal cell, and they are normal cells. They're just normal cells that grow in the wrong place. So it's a lung cell, lung tissue cell, or no, here's a good example of that is a mole. It's also polyps. Polyps can be just the normal cell that's grown in the wrong spot, and it can be benign. Moles, let's see, endometriosis can be like some some of the uterine tissue growing outside of the uterus in another way, and so it's causing problems elsewhere, like in the fallopian tubes. And then these are just features of the malignant tumor cells. They're just very, very, very chaotic. They have that rapid division, have abnormal chromosomes. They loosely are here together so they can break off very easy. They lose this specific function. They're just kind of run amok without any reason or rhyme or reason other than to take over organs and spread. And when they spread, basically they get in the way of the function of that organ. And that's how they can really cause damage to the patient. Some more visuals here on the difference between the benign and malignant tumors. Carcinogenesis or oncogenesis is just a term used to define the development of a cell into a cancerous cell. You can just review all these terms just to become familiar with them, so give you a little bit of background information on the development of cancer. There's a lot of tables you can review in your chapter regarding cancers. Chapter 21 in your Iggy book has a lot of great tables you can review to kind of look at the differences and the terms that are listed here. These terms here are terms that are associated with how a malignant tumor can metastasize. And the next slide actually is a visual for you to look through that, so we'll go to that slide. These are steps of metastasis. So this is the initial growth of those tumor cells, those malignant cells. And then it just essentially just spreads. And here's the key thing here is where it gets into the blood supply. So it gets into the blood supply, and then that, as you can see here all the little cancerous cells are now being spread to another part of the body through the blood supply. A good thing to review in your book is the description of a primary tumor or a secondary tumor. The reason we look at that is because basically the original tumor is the primary tumor. And then when that primary tumor spreads to another area of the body, to another organ, and forms a tumor there, it is called the secondary tumor. Just something I want you to understand. So if it's breast cancer often will spread to the lung and will cause a tumor in the lung. So the patient does not have breast cancer and lung cancer. The patient has breast cancer that has metastasized to the lung. So the important thing about understanding that, and there's a lot of, I encourage you to look at the tables in your Iggy book. It's common sites of metastasis for different cancer types. It tells you, just for example, like breast cancer, the common sites for it to metastasize to are the bone, lung, liver, and brain. So what happens is when somebody's diagnosed with a breast cancer, we know that it often can metastasize to these other areas. So if it's a highly a large tumor that's in the breast that looks like it's probably spread to the lymph, the doctors will go ahead and scan this patient's lungs, probably a CT scan, to check to see if that breast cancer has metastasized to the lung. So that's just kind of why they look at like primary, where did it start? Where does it, okay, we figured out where it started now. We know the areas that it typically metastasized to, so we better check those areas to make sure that it hasn't metastasized there. Review cancer grading and staging in your book. Basically, these grading scales and staging scales have been developed in order to determine the degree of malignancy of a tumor to form a common diagnosis table so that it's understood like how much the cancer has metastasized, what kind of cells they are. For instance, the grading scale is kind of more about the cellular part of the tumor. So like a grade 1 It means that the tumor cells are differentiated and they closely resemble a normal cell from where they started. It's a low grade of malignant change, as opposed to grade 4, which means that the tumor cells retain no normal cell characteristics. Determination of the tissue of origin is difficult because these cancerous cells are so abnormal. So grade 1 is a little easier to detect and treat. Grade 4 is a little trickier. Staging determines the location of the cancer and its degree of metastasis. So if you look through that staging table in your book, stage 1 is less metastasis, a less degree of metastasis than stage 4. Stage 4 indicates that it's more of a metastatic cancer. So basically, you don't have to memorize these, but you need to know if somebody says it's a stage 4, grade 2. So that means it's metastasized if it's a stage 4. Grade 2 would tell you that the cells are somewhat abnormal, but we can still kind of tell where they came from. So just kind of review that just so you can have a conversation with somebody about, what these tables mean and just what they mean, and why they're staged and why they're graded. And a lot of that helps the doctors and the providers to determine the treatment. So the degree of metastasis and the degree of change in the cell determines the type of treatment, and that's why they use it. One thing I want to bring up really is that our goal as nurses and educators, health educators in the community, our goal and our job is really to let people know that cancer needs to be found early and treated early. The prognosis is so much better. So in the next few slides, we'll talk about our role as a nurse in teaching. This is just another visual picture as far as the staging. I just think this is a really good picture because it shows you this is a much larger tumor, and it has spread to the tissue, and that would be your stage 4 here. And so this makes sense. This is your stage 1. It's much smaller. There's not as much, it hasn't spread to other tissue yet. It's more localized. Just a good visual to help you understand that staging table. So this is where that education comes into. These are all factors that can create an environment for a cell to become a cancerous cell. Oncogene activation means that is how cardiogenesis occurs. So it's activation of the cancerous cell. Typically, when a normal cell is exposed to a carcinogen, that's when it can be mutated and damaged. And these carcinogens are things in our environment, which I kind of already mentioned. And there's some viral, there's physical, there's dietary things, there's personal factors. This kind of things we can't change. We can't do anything about. Basically, though, we just need to let people know that if you have genetics, that if you have a lot of family members that have cancer, you're more likely to have it. It's a risk factor. If you're getting older, it's a true fact. The older we get, the more at risk we are for having cancerous cells. And an abnormal immune system could open us up to having a cancer diagnosis. And a lot of those things we just can't help. But what we can do for these things right here is teach our patients to take care of themselves so that, as they get older, they're still healthy. They're still, able to kind of fight things off a little bit better the healthier they are as they grow older. As far as the viral carcinogens, there's some listed in your book. Those are like the human papilloma virus, which causes cervical cancer. Epstein-Barr virus, which is also known as mono. can cause some lymphomas. It's been known to be a precursor for some lymphomas. Hepatitis C also is known to be a precursor for liver cancer. Dietary factors are also listed. So some of the things that put us more at risk for developing cancer is animal fat, any kind of prepared lunch meats, anything with preservatives in it. It's known to increase our risk for developing cancer. Alcohol consumption, of course, I think I already said. So the bottom line in all this stuff, you hear in the news all the time, you shouldn't eat red meat, you should eat organic, you should have no preservatives, high omega fat, high omega-3 fatty acids and things like that are better for you because they help you combat cancer. All the fresh green leafy vegetables are so much better for you. So even though it sounds boring and difficult to maintain a diet that's healthy, you actually can it's not about a weight thing, it's not about a vanity thing. It can really be about protecting yourself against cancer. So it's good to talk to patients about. I know that, red meat is good to taste, but let's see if we can maybe switch over to maybe just like some chicken that's better for you, not only for weight, it's your general health, and it's prevents you from getting cancer as well. So just look at kind of these factors here and just think about how a nurse could educate a patient on what their risk factors are, if there's any that they can do anything about, and then if we identify risk factors, we need to make sure that they're getting the screenings done, like pap smears for cervical cancer, colonoscopies for colon cancer, making sure they're getting their screening tests done to identify cancer early and treat it early, because the prognosis is much better. Just some factors, like I said, that we need to teach our patients to avoid those potential carcinogens. Just modify their diet, remove any of those things that are at risk. Sometimes there's there's precursors, some polyps, like in colon cancer, they might be benign, but if they leave them there, they could turn into more of a metastatic cancerous cell, so they'll remove them. And then just the knowledge that people have had polyps in the past will require that they get a colonoscopy more often because they're at higher risk. So lots and lots of things to educate our patients about as far as cancer prevention. These screenings for cancer prevention essentially consist of a provider, a healthcare provider, asking questions about risk factors, identifying what they're at risk for. If a provider identifies that someone has a family history of certain types of cancers, genetic testing could also be done to either confirm or rule out a person's genetic risk for some specific types of cancer. It's important to know that these don't diagnose cancer. They only provide risk information. One thing that I want to point out that's a very common good tool to share with your patients is the 7 warning signs of caution, and they've developed sort of a fun little way to remember what these 7 warning signs are. 7 warning signs of cancer. So the C stands for change in bowel habits. A is a sore that doesn't heal. U stands for unusual bleeding. T stands for a thickening or a lump, like a breast tissue thickening. I stands for indigestion, or difficulty swallowing. O stands for obvious change in a wart or a mole, and N is for a nagging cough or hoarseness. So that's just kind of a good way to help patients understand the 7 warning signs of cancer. These are just put out by the American Cancer Society, and if a patient has any of these 7 warning signs, they should report them to their physician for testing. And then again, it's just to identify any kind of a cancer early so that we can treat it early. The prognosis is much better. These are just some questions that you can use for practice. I encourage you to try to answer the question and then check your answers in the comment section of the PowerPoint. So now we'll just talk a little bit about once someone has developed cancer, what problems it can cause, and how we should provide care for them as nurses. So once cancer develops in an organ and destroys its normal tissues, it can decrease the normal function of that tissue or organ. So that can lead to problems such as a reduced immunity, sometimes reduced blood producing function. So if somebody has like a leukemia that's a cancer in the bone marrow, that can affect their immune system. It can affect their red blood cell count. It can affect their platelet count. So those are just some problems. Altered GI structure and function. If they have a cancer growing in the GI tract anywhere, like colon cancer, esophageal cancer. And it can, of course, decrease respiratory function. The decreased respiratory function can come from lots of different things, like a low red blood cell count could, decrease their oxygen supply. Any kind of a lung cancer tumor can affect their breathing pattern. Typically, surgery is one of the earliest known treatments for cancers. These are all the different types of surgeries that might occur for somebody who has cancer, and you can just kind of review these in your book. You don't have to memorize them or anything, but just know that kind of different things that we might do for treatment. Prophylaxis is somebody, like if we determine that somebody has like a polyp, like I mentioned earlier before, they might remove a benign polyp from the colon so that it does not develop into a cancer. That would be prophylactic. Diagnostic would be a biopsy. That's where if we see a spot in someone's lung that we look at a CT scan and think it's probable cancer, they'll go and they'll biopsy that tumor to determine if indeed it is a metastatic cancer or a benign cancer. Curative surgery hopefully would mean that we could, if there's a tumor available or tumor there, we could actually remove the tumor and cure the patient. Palliative surgery. Sometimes palliative surgery is just to, if someone is uncomfortable, we really cannot cure them, but it's more we do the surgery to make the patient comfortable. Reconstructive surgery would be maybe following like a breast lumpectomy. Sometimes people who have throat cancer require reconstructive surgeries to remove a tumor like from their neck and then do some reconstructive stuff. Things like that. Reconstructive could also be a bowel resection with a colostomy. So lots of different surgeries that are available for someone for a treatment for cancer. Postoperatively for any of these surgeries, we should, you guys know a lot about postoperative teaching, so you would be able to take care of these patients. Cough in and deep breathe and monitor for infection, monitor for pain. It's all of those things. And then there are some additional needs for patients who have cancer undergoing surgical treatment. Of course, there's a lot of psychosocial support. A lot of times, for instance, a breast cancer patient having a mastectomy, there's a lot of psychosocial things involved in that kind of surgery for cancer. It's a lot of body image problems and things like that to cope with. So it's a little bit different than your typical surgeries because of that. Really, they're going to need a lot of teaching, support groups. Just thinking like perhaps a patient with a colon cancer has a colonoscopy or has a colostomy, which is where they create a stoma and then they have to wear a pouch. It's a lot of teaching, so that's a little bit more specific to a cancer patient surgery. Radiation therapy is another way to treat cancer. purpose of it is to destroy cancer cells, and this is typically an external source of radiation that we expose the cancer cells to, and hopefully it will has minimal damaging effects on the surrounding normal cells, and maybe used to cure, control, or just kind of as a palliative care treatment. Usually it's typically a local treatment, so the patient just in that area where the radiation is directed will have the effects of the radiation. Like if somebody gets to the chest, lung cancer, just that area there where they direct the radiation will have some damage. And typically it's like skin. It causes some skin dryness, causes the skin to be very raw, hair loss to that area. So it's just the area that the radiation is directed at that has the side effects. Lots of different ways to deliver radiation therapy. Teletherapy is a radiation from the external source. That's what most of us are used to hearing about. It's patient doesn't make them radioactive and they're not hazardous to others. Brachytherapy means close-up therapy. The radiation source comes into direct contact with the patient. This does make the patient a potential hazard to others for a certain period of time. So there's a lot of teaching that goes along with the brachytherapy. The type of radiation is chosen by the provider, the physician, and it's dependent upon what type of cancer the patient has, whether it's spread to other areas of the body, where it's at, where the primary site was. It depends on a lot of different things, whether radiation therapy is appropriate for a patient or not. So this slide just again lists the teletherapy, which is an external radiation method, and then brachytherapy is more where they actually might implant the radiation to the patient. And then, so the patient with brachytherapy is actually hazardous, and they have to be in certain types of isolation where it's limited who's exposed to the patient. And typically the nurses that go in the room and take care of this patient have to wear lead to protect themselves. They should also wear the badges. The nurses that take care of these people should wear the badges to determine the level of radiation exposure that they've had. The idea of radiation is that it will kill the cancer cells, or hopefully like maybe shrink the tumor that has developed. It can be used in conjunction with chemotherapy. It can be used alone. Sometimes they'll use it before surgery. So they'll try to do radiation for a couple of weeks to shrink the tumor so that it's more easily removed by surgery. These are just a few things that are the side effects. Just think about ways to take care of a patient with these side effects. Sometimes like chewing gum, sucking on candy and stuff like that can help their altered taste sensations. Fatigue, allow them to rest. Local skin changes. They need to take very good care of that skin and be very gentle with it because it's pretty raw, so they should not be scrubbing it. They should use very mild soaps and lotions. Don't use lotions that have fragrances and things like that. Those are more irritating. Aloe is a good thing. A natural aloe is good for that. And then like an Aquaphor, something that is more of a healing moisturizer, would be good. And usually they're either their radiation therapist or their physician will give them recommendations as to what they should use for those areas that are kind of irritated by the radiation. Sometimes it can cause some bone marrow suppression. So what that means, think about what that means. That means that possibly they could have a poor production of their red blood cells, white blood cells, or platelets. So think about what that would make the patient look like. Of course, if they don't have white blood cells, they'll have an impaired immune system and be susceptible to infection. If they have low red blood cells, they could be tired and anemic. And then if they have low platelets, that makes them at risk for bleeding. So just think of all those things. I think this pretty much lists everything that I just talked about in the last slide, but just some more things to make sure you point out to your patient as far as care while they're having radiation treatments. Chemotherapy there's lots of different types of chemotherapy. The types of chemotherapy selected for each patient is different. Chemotherapy is drugs usually identified to kill the cancerous cells, to stop in many different ways. For instance, antimetabolites are thought to decrease the ability of the cancerous cell to replicate itself because it decreases their metabolism, so they lose the energy to be able to replicate themselves. So all of them work in a different way, and typically people will get like a little combo of chemo, so that we can try to kill the cell in a few different ways, kill the cancerous cell in a few different ways. It's kind of like the HIV meds that we give. We give a little cocktail of it so that we can kind of target different areas of where that grows and where that's able to mutate. So we do kind of the same thing with the chemotherapy. The only issue with chemotherapy is as we give them medicines that kill their cancerous cells, sometimes we can also kill the good cells. So there's a lot of side effects that can occur with chemotherapy treatment. So chemotherapy is a systemic therapy. So what that means, as if we compare it to radiation therapy is topical. It is focused on one certain area. It's localized. Chemotherapy is systemic, which means it can have an effect on all normal tissues as well as the cancerous cells. Dosage, again, is according to the physician and how they decide the dosage and scheduling is. Typically, dosing is decided upon by the patient's weight, and then also the type of cancer they have. And also, they try to give the chemo that's going to give them the optimum dose with the least amount of side effects. Chemotherapy drugs are typically what we know as vesicants, and they're administered, most of them, there's some that are administered a little bit different, but most of the chemotherapy drugs are administered through an intravenous route. And a lot of them are what we call vesicants, which means they have a very acidic pH to them. So it requires a central line that we infuse them through a central line. A central line is just a line that goes into one of your patient's larger veins. If we put that vesicant drug in the small peripheral veins, it actually can leak out into the tissues and can cause what we call an extravasation, which can actually, that highly acidic medication leaking into the tissue can cause a very harmful reaction. I think that's in our next slide. This is a picture of somebody who's had a chemical burn from extravasation of a chemotherapy drug. So it can actually literally burn the tissue that it leaks out into. That's why we have to have special nurses. A nurse who administers chemotherapy has to have special training and certification. And that's because of just these big side effects and these big safety concerns with administration of chemotherapy. But it's just important that we know why they have to have a central line. The other thing that a central line allows us to do is do frequent blood draws and things like that we need to do for these patients too. We're probably checking their blood counts frequently. We're checking for the effectiveness of the chemotherapy frequently. So with a central line, you can draw blood off of it. And those are the portacasts that are implanted in the patient's chest. It could be a PICC line as well. Typically it is a portacast because they're a little bit longer. They last a little bit longer than a PICC line does typically. So just make sure you're familiar with the terms extravasation and vesicants. Vesicants just means that it's a highly acidic pH medication that we should not administer through a peripheral IV site. Extravasation just means that the chemical has leaked out into the patient's tissues. Again, you have to, like I said, typically nurses who administer chemotherapy are highly trained, and they have a certification for administering the chemotherapy. And they have to wear special protective equipment in order to do this. It's really important to think about how this makes your patient feel. When a nurse comes in holding a drug and they're all garbed up, but yet they're administering it in someone's veins, so it makes them a little bit uncomfortable. But it's important that it gets explained to them what's going on, why we're protecting the nurse from exposure to the chemotherapy. There's lots of precautions that a nurse would have to take also if you are taking care of a patient who just had chemotherapy. There's precautions that typically 24 to 48 hours after the last dose of their chemotherapy that a nurse has to follow. Typically, that's like double gloving, and just basically you are protecting yourself from being exposed to any other bodily secretions because that could expose you to the chemo. I want to encourage you to look through your module topical outline and look at those different classifications of the chemotherapy drugs and kind of review each classification, kind of how it works. There are some topical chemotherapy meds as well, but there are oral chemotherapy meds where they might actually just take a pill, but the majority of them are actually IV, which need to be administered in a central line. But just review each of those, kind of look at the classifications of them, and just kind of look through. I encourage you to look through your Silvestri book to look at any kind of nurse alerts regarding any of those types of medications. So, along with chemotherapy treatment becomes a lot of side effects because, again, we're actually killing some of the good tissue along with the bad tissue. Typically, they'll do an induction therapy with chemo, and what that is a really intense first few weeks, dosing them up pretty good with the chemotherapy to completely kill the cancers. So the side effects are pretty high. It's pretty harsh on the patient to go through like that induction therapy. Just look at these side effects and think about what your patient looks like. Neutropenia means that their neutrophils are really low, so that puts them at very high risk for infection. So think about nursing care related to a patient who's at high risk for infection. Make sure you could take care of that patient. Impaired clotting, they're at risk for bleeding. That's a big deal. You got to make sure your patient's safe and doesn't fall, especially not fall and hit their head. If they fall and hit their head, they're going to be at risk for a big head bleed. And think about what that patient would look like. A lot of nausea and vomiting that can lead to dehydration. Think about a patient that you would that's dehydrated, how you would help that patient. Fluids. Monitor their lips. Make sure they have some chapstick, things like that, to kind of help support them. And give them fluids as allowed by their medical diagnosis. Alopecia, they're going to lose their hair. That's a body image disturbance. Think how you would support them with that. Give them referrals to places where they could get wigs, etc. Mucositis means that a lot of times the mucous membranes in their mouth is affected by the chemo. So they're at risk for getting like fungal infections in their mouth, and that causes a very sore tongue. Sometimes they can barely eat with this stuff. So we need to get them meds to treat that, and then get them irritating foods that they would be able to eat that wouldn't irritate their sore mouth and sore tongue. So like hot foods would not be ideal for them. Anything very, very cold might not be the best thing either. So just think about all those different things. This is just a slide that kind of describes how chemotherapy can work against the cancerous cells and can work to treat a patient who has been diagnosed with cancer. This is just a list of those medication categories that I told you to make sure that you kind of review. Probably a good place to look these up, like I said, is your Silvestri book, because the Silvestri book is really good about pointing out the highlights of what you should know about each of those meds listed on your topical outline. The following slides are just, again, some questions for you to just practice answering questions about cancer. I encourage you to try to answer the question first and then look at the answer that is posted in the PowerPoint in the comments section. This concludes the presentation for Nursing 150 for care of the patient with cancer.